people who have psoriasis and then have psoriatic arthropathy, or who have other T-cell mediated diseases in which you want to suppress the T-cell, you use cyclosporin. And cyclosporin by itself has a dose-related effect on renal functions too. So not only and with nephrologists, we also use it for transplant in the AL nodes, where that's calcineurin inhibitors, which is both cyclosporin and tacrolimus, both have a nephrotoxicity, which causes mainly is tubular and causes a lot of damage to the kidney. Methotrexate has to be, and I'm just mentioning methotrexate here because it is excreted by the kidney, and leads to when kidney function is impaired, it leads to drug accumulation. So pre-existing diseases of the kidney or bad renal function may be a relative contraindication to its use, because the other side effects of methotrexate, which happen at higher doses, would happen at much lower doses of methotrexate, because the methotrexate will not be able to be excreted by the kidney and keeps accumulating. So it is essential to assess the renal functions prior to starting methotrexate therapy. If it's okay, then make sure that the urine is alkaline, so the excretion is better and crystallization does not happen. NSAIDs, phenytoins, and other drugs that can sometimes affect the combination should be seen to be made sure that they're not there. And the most shared disease, I presume, would be lupus. And lupus, by and large, has a 60 to 70% chance that people with lupus will have some degree of renal involvement or have lupus nephritis. It is clearly seen much more in the nephritis is seen much more in children or younger lupus patients and in the elderly patients, but it's seen clearly at all ages. Unfortunately, those who do have lupus nephritis, 5% to 20%, normally about 7 to 10%, would end up having end-stage renal disease requiring replacement therapy. It is apart from carditis and cerebritis, the most dreaded complications of lupus, because the long-term morbidity and mortality and your degree of immunosuppression would clearly depend upon the severity of these systemic involvements, mainly. We all know that the pathogenesis is related to a disorder in regulation both of apoptosis and clearance of these products of apoptosis, and eventually immune deposits in the glomeruli, which can be at three different places: the direct binding or to binding to circulating antigens, then deposition of preformed soluble circulating immune complexes, then get deposits in the kidney. Those lupus patients who are likely to develop lupus nephritis, of course, the easiest thing to do is to monitor them, which is looking at the urine, to look at the RBCs, to look at proteinuria, to look at renal functions. And those people who have a very high anti-DNA, people who have who remain ANA positive even with treatment, and people who have very low complement levels, and those that have Anapla syndrome. So it's not that the others can't, but when you have these combinations, the likelihood that they would have lupus nephritis in an SLE patient is quite high. And it's important to know that once the kidneys are involved, one really needs to know what the involvement is. I've just put in the new classification, and it's not meant to be remembered or to be seen, but to know that there is varying degree of involvement of the kidney in lupus. It's not, lupus nephritis is not one disease. Lupus nephritis is about 7 diseases with 8 subsections. And all that depends on your prognosis of the kidney. On that it depends the degree of immunosuppression that you are going to use or not use, because there are certain degrees, certain involvements of the kidneys in lupus in which the treatment is futile. And so therefore, unless you know what the disease is, at what level your disease is, it's not going to be known. And unfortunately, the only way to know is an invasive procedure, which needs to have a renal biopsy, which needs to be looked at both ideally by light microscopy with immunofluorescence, and if possible by electron microscopy. But without knowing where the person is in lupus nephritis, it's very difficult to prognosticate and or to give treatment. So, briefly in conclusion, there are many things that we both see, mainly SLE and rheumatoid arthritis. I didn't mention rheumatoid arthritis because rheumatoid arthritis, apart from the drugs, we all know that the second major involvement with rheumatoid arthritis is the long-term inflammation and causes of amyloid. And then deposition of amyloid in the kidney, which then causes renal failure and then destroys the kidney completely. There are other diseases like systemic sclerosis, which we all see, sarcoidosis, which we all see. Some of them were mentioned by Mahanaz and the rest that we all see together. I think the only take-home message that I would leave with is that regular screening is essential. Regular screening with one at looking at their blood pressures, two looking at the renal functions by looking at their not only by the creatinine, if required, a creatinine clearance, and by estimating a GFR, because as you know, serum creatinines may not give you the accurate estimation of GFR, and looking at the urine for sediments and for proteins. And if protein is present, quantifying it. If one does not know why these things are present, then to find out why they are present, which means by doing a renal biopsy or by looking at other things. I don't think the rheumatologists and nephrologists see each other too closely together for many patients that we should be seeing. And I think that is one essential message, that whenever there is a renal involvement or whenever there is a rheumatological involvement in renal disease, I think the cooperation between the two has to be extremely high. These are some of the references that I took, and thank you.